Thank you very much. Well, I'm going to talk again about, as you said, something really quite different. The new challenges and the new excitement in terms of the prevention of cervix cancer. We now have two major approaches to deal with cervix cancer. In the past, we very much relied on screening to be our primary modality. We now have vaccines which are effective against about against the virus, which causes about 70% of the cancers. Now, these are slightly out of order. So, first of all, I want to tell you a little bit about the vaccines. There are two vaccines that have been licensed, one called Gardasil, one called Cervix. They're licensed in most developed countries, typically for age 9 to 26, but also in older women as well in some countries. The vaccines focus essentially on the two major types of the human papillomavirus that actually cause 70 to 75% of cervix cancer. They're type 16 and type 18. And both vaccines are highly effective in preventing infection from these viruses, but they only work if they're given before you're infected. The viruses are sexually transmitted, so they typically only work in girls before they've been sexually active. So most programs focuses on girls aged 12 to 15, trying to give vaccination beforehand. And in some places, catch-up vaccines for older girls or older women are also being made available, but that's more of a controversial issue because the vaccine will not be as effective in older girls and young women because they've already had some infection. So, sorry, we're going to have to just jump backwards. I want to, because now there are a range of issues, as I said, that the age at vaccination is a key issue. It looks like early teens is the most effective time to do it. If you're going to vaccinate older women, basically the vaccine will only work if they haven't been exposed to the virus, so it's probably important to determine whether or not the virus is there. The most simple way of doing that is checking if the virus is there at the moment by when one does a cervical smear. You can actually look for the human papillomavirus in the smear, make sure that's not there. If it is, they need treatment, not vaccination. And if the virus has come and gone, there'll be telltale hints of that by looking in the blood for antibodies to the virus. Another major issue is how durable the vaccine is going to be. There's an expectation and a hope based on hepatitis and some other vaccines that actually one set of, basically you need three shots in one course over about a 6-month period, that this might actually be effective for a whole lifetime. But that's still uncertain. We don't have long-term follow-up. So will a booster be required 10 to 15 years later is still an important question. And then vaccination of men is also a major issue. Men do get some cancers caused by the human papillomavirus. They also get genital warts, which causes several problems. But the main gain is for women. So vaccinating men, the main gain there will be to stop the spread of the disease by herd immunity in the long term, by stopping men from passing the virus to women. Now, the other area, and the one that I think is important, is not overlooked, is the fact that, in fact, the vaccine only works for girls, and it really is the approach for the next generation. We mustn't forget the current generation of women, and their screening is really the major option. And I think we're beginning now to move away from the old approach to screening, which essentially looked for cytological cellular changes in cells taken from the cervix, and to begin to look for the same virus, this human papillomavirus, in the cervical smear that's taken. And this has been shown in a number of studies, about 8 studies across all of Europe comprising more than 30,000 women, that in fact, if you test for the virus, you're much more able to actually detect women who have precursors to cancer, the so-called CIN2 and 3 lesions, which, if left alone, will progress to cancer. HPV will pick up 96% of those, so it's very, very effective, whereas cytology, the conventional approach, is only picking up about half of them. And that's highly variable across countries and centers. It's as high as 75% in some places, and as low as 25% in others. So cytology, which is what we've relied on, is not a great screening test. And half the women that actually have disease are told they're negative on their smear. And it's why we have to do smears so often, because in fact you need about 3 negatives before you actually know you're negative. And it looks like HPV can actually deal with that. The other exciting thing which has just come out over the last year is that in fact when you're negative for the HPV test, the duration of protection is much, much longer than when you're negative for a smear. And this graph just shows some of the data. The blue line shows you if you get a negative smear and you're told you're all right, typically 1% of those women will actually develop high-grade lesions that will progress to cancer if not treated over the next 5 to 6 years. Whereas if you're negative for the HPV test, the rate is about 1/5 of that. So not only does it, we're finding all the disease that's there at the time, and that gives you a much longer duration of protection. So screening will have challenges in the post-vaccination period because, of course, once women are vaccinated, fewer of them are actually going to have developed the precursors and go on to get cancer. So current screening will be less cost-effective because there'll be less disease out there to detect, and we're going to need better methods. And it's another reason, I think, for wanting to move to the HPV test. Instead of being a manual test where slides are taken, where cells are taken, put on a slide, and they have to be looked at by a microscope subjectively, the HPV test is it's a molecular test. It can be completely automated. You get yes/no answers that work extremely well, and it's going to be better because of the higher sensitivity, even when disease is less common. Just now to summarize, I think the main message and the thing that we do need to get across to European governments and providers is that cervix cancer is virtually 100% preventable. It's the only cancer for which there's a single known cause. Over 99% of cervix cancers actually have the human papillomavirus in them. This virus is the single cause for this one cancer, and that's the only case where we have such a clear cause and effect relationship. When the infection if you get infection, many infections are transient and will not cause cancer. About 90% of them, the women will manage to clear the infection and there's not a problem, 90 to 95%. It's only when the high-risk types of the virus persist for more than a year that cancer can develop. So persistent, an infection that remains persistent with one of these high-risk papillomaviruses is the key fact that leads to cancer. We know that quite clearly now. Vaccination can prevent infection. The current vaccines only against the 2 major types, types 16 and 18. There are vaccines coming along which promise to look at many more types and maybe will ultimately eliminate the need for screening. But at the moment, only 2 types are prevented, and the vaccines do not work once you're infected. It cannot eliminate an infection once it's there. Screening can identify the precursors which are treatable, and screening clearly is still the only approach that's going to be effective in women over the age of 20. So the vaccines are effective, but they're mostly, this is the great hope for the next generation. The current generation is going to continue to need screening. Screening is going to be more difficult in vaccinated women. It will be less cost effective. But there are a number of approaches. We need to move towards molecular testing for the virus. We probably can screen at longer intervals because the test is much more effective. There is emerging evidence that self-sampling works quite well for HPV testing. Women will not have to go to the doctor. They can actually use a tampon or a spatula and actually take their sample and send the sample in, much as it's done for other things now. If vaccination is really going to be helpful in terms of helping us to modify our screening policy, it's going to be important that we actually have registries to know who's vaccinated and who isn't, because coverage won't be 100%. And screening really does need to change to HPV testing as the primary approach. It's a much better test. We're bogged down a little bit now in a technology which is over 50 years old. It works moderately well, which has, I think, made it difficult to change. But the time really is now right to change, to move towards HPV vaccination and HPV screening. And until we get these new vaccines which are being developed, screening is going to remain important. So thank you very much.
Thank you again.